Okay, so I'm going to talk to you about addressing ankle injuries. They're very common. Very commonly, you'll see an inversion type of injury. That's what was going on in here. And so we're just finishing this one up. So the initial issue is to address the tibia, fibula, long bone type of thing. And that's very common, sometimes the interosseous membrane. Once we get into the lower part of the extremity, we see the distal fibula, distal tibia. We have to consider talus, midfoot, cuboid, cuneiforms, navicular, and the calcaneus. Sometimes we have parts of the forefoot, very commonly fourth and fifth metatarsal. So the question is, what do you address first, okay? So we talked about the tibia and fibula, that's first and foremost. There may be neurological components that are caused by the same injury that affect thoracolumbar spine. But then once you get into the foot, you want to break it down to deciding which one is to be treated, what the order of treatment is. So in general then, a larger structure, which has more mass, if it's showing up, is going to impose a mechanical stress on smaller structures. So for example, if the calcaneus or talus shows up, that may influence your ability to treat things like the cuboid, for example, or even the lateral malleolus, the distal fibula, because that's going to have superimposition of mechanical stress coming from the calcaneus, the talus, and so on. And so you want to work basically from the larger structures towards the smaller structures. This is a similar principle we talked about with treating the pelvis, where you have the greater trochanter showing up, but the ilium is also showing up. So by treating the ilium first, you allow access to the greater trochanter. Similar also to the rib cage. If the rib cage is injured directly or indirectly, and that needs to be treated to some extent before you treat the thoracic spine. Now, you do have to still sometimes go back and forth, and that's normal. Okay? So a way to set things up to get into the ankle and the midfoot, because a lot of times the person's foot is going to flip out to the side in rotation. So one of the ways you can address that is by supporting the knee with a couple of bolsters. And we can do that, we can create a little bit of a wedge here. Let it drop, that's good. Okay? So that will tend to keep the foot in greater alignment. I'll probably wedge it just even a little bit more. Okay, let's drop it. Okay, so now I've got the foot in a more upright position. So then if I want to address issues like the talus, calcaneus, and then I can place another bolster supported under the heel, under the calcaneus. So if I want to do things, for example, like treat the talus in the diagonal axis, the talus and the lateral compartment like this, right, or the medial, okay, this can also be used. And this is also a position you can use to treat the fourth and fifth metatarsal, lining it up with the cuboid and the calcaneus, so coming in like that. So this is a big pattern, which is commonly going to show up in these inversion type injuries, right? And then you can move into more local areas, so possibly treating the lateral part of the talus like this, and you can even do a anterior-posterior containment on the fibula, although in many cases it's easier to treat that in side posture. You may find you may do some fine-tuning like this, so I've got it contained like that. All right, so going from big to small, supporting the knees so that it's going to be lined up in a anterior-posterior position, so it's not too far rotated out, okay? And you can also treat right through the malleoli this way as well, okay? So lots of possibilities for the midfoot as well. And okay, so just some ideas on positioning and sequencing of treatments for the ankle and foot. Thank you.